place, and I just want to talk a little bit about the sort of pressure distribution and why that's important and how we can modify that. I don't want to spend excessive time. I realise I've got far more slides than I have time, so I do want to make it a lot more practical. So I'm going to try and start a bit of that, and this afternoon will all be practical, really. So whatever you haven't done theoretically, you'll have as part of your pack anyway. So this is Renzo's picture. Many of you will have seen this at different times, and it's really just this. I don't know that anyone really understands what it means. It looks pretty, and it's got some nice pictures on there. I think the idea generally is that in the thorax we have relatively neutral or negative pressure potentially, and obviously that pressure is going to alter with what the diaphragm does. As the diaphragm descends, it creates a negative pressure within the thorax, and that draws air in. Without that process, obviously we wouldn't be able to breathe. But the implication for that is that it alters pressures in the abdomen and in the pelvis. And that if the diaphragm is functioning well, then you're going to get this lovely massaging effect. And all of us, I think, will have heard this. Sorry, I keep forgetting, I've got to stand over here. Right, all of us will have heard this at some point in our training, and you know, we intellectually you sort of believe it, but it's really amazing when it actually happens in your hands. Often with visceral, what put me off a lot with doing visceral work was that, you know, I just think I can't feel motility, and I don't know what I'm on, and I don't really know if it's changing, and you know, it's all a bit vague, and I'm not sure I can justify this if I've got a tutor breathing down my neck. And so it was all, you know, it didn't become part of my regular routine. But one of the things that Renzo really teaches beautifully about this is that, you know, you find an area of tension. And even if you don't know what it is, you know, you just know it doesn't feel right. You know, you've done enough to know it's not comfortable, the tissues are not right. And then if you can get the patient just to breathe, particularly down into the lower abdomen, you can just get them to overcome their fear of having a domed abdomen, because none of us want that. We all want our nice toned six-pack, and this bloody nonsense, don't get me started about core stability and all that sort of stuff that really, I just think is mostly nonsense. But anyway, that's another thing. But it has created this idea that people have got to walk around with rock hard abdomens, you know, to create, and of course it's totally non-physiological, because it's the only bit that can actually move, because you've got bones sitting in the back, so that's not going to move. When you breathe in and out, you're going to have a little bit of a loss of lordosis, so somewhere it's got to give, and if you tense your abdomen up, then it's all going to go down into your pelvic floor, and so you don't necessarily want that. You want your abdomen to be able to move with breathing in and out, so otherwise where's that pressure going to go as you're breathing in and out? Anyway, that's another thing. But the point, what I was going to say is that when you've got your hands on this area of tension, and you get someone to breathe, just breathe down to where the tension is. And just, it could be with a suprapubic contact, working on a cesarean scar, and you just apply a superior stretch, just gentle, but enough that you feel like, okay, I've got a bit of tethering there, and I'm now just going to sit with that tension. And now I'm going to ask my patient just to breathe in and try and push my thumb away with the breathing. And just ask them to do that simple movement. And you feel this immediate, within 10, 15 seconds, you feel a softening and a give within those tissues once they get the breathing right. First time, they don't get it right, you say, no, just keep on trying right down to the abdomen, and you may have to give other cues with your hand to be able to guide them as to where you want them to begin to breathe. Sometimes their breathing pattern is so dysfunctional that it's all the movement happens in the thorax and nothing is happening in the abdomen. But as soon as you get that engagement with breathing, that's when you get these amazing changes happening within the organs, almost instantaneously. And so you just think, if I could just get my patients to breathe properly, they wouldn't need any of this other manipulation stuff. It would all just be fine. And I think that's the reality, is that if we can get people to breathe properly, so there's a value of breathing properly in yoga, but sometimes they can't do it because they've not ever learned how to. There's some interesting work, if you want to look at that, with a chap called Pavel Kolar from the Prague Institute on rehab, and he's done this whole role looking at the role of the diaphragm in postural formation in babies. And if you don't learn that reflex right from day one, then you never learn how the diaphragm works. And he does some work which looks very like fascial unwinding, which is taking people into these primitive positions that allows this neural reflex to take place, where you're mimicking these early reflex patterns. And then after that, people can then recruit their diaphragm properly. So it's very interesting looking at that. And you know, I think we can do much the same thing with our hands-on contact. So we can just guide the diaphragm to function properly. In fact, while we do that, why don't we do that now? There's a really good exercise which we can do, just sitting there. So if I can have a model first of all, and then you're all going to practice this. One of the things is, you know, we talk about working on the diaphragm a lot, and I just want to show you another approach that you may have seen. It may not be that interesting, but I found it really useful. So if you can line onto your back, Ross, thank you.
Michael, what was that guy's name again?
Kolar, Professor Kolar, K-O-L-A-R, and the approach he uses is called dynamic neuromuscular stabilization, and his whole system is based on pediatric reflexes, how they learn these reflexes and their pathways, and his view is that if you deviate from those, if you've missed one of those steps out, then everything else built on top of that is incorrect movements, and so you have to retrace and take the body back to those early primal reflexes, and then you'll get proper adaptations postulally. So there's really interesting work. He did the course here, I don't know, a number of years ago, and it was really amazing, but you know, I keep thinking I'm going to go over there and, you know, it's better. But it's another one of these things where it's time, you know, in many lifetimes. Anyway, so we're looking at the diaphragm. So if you imagine, you know, you're trying to work on this lower abdomen. So Roz, I know, already knows a lot of this. So if I get her to ask her to breathe in, so if you breathe in, oh no, she doesn't. Oh look, you see, so we're not getting any movement down here at all. So it's all happening up here. So very typical of a patient here. So she breathes in up here and she's not breathing in down here. If I say to her, can you now just breathe down into your lower abdomen if you can? You see, she's really struggling. I'm not getting much movement in my hand here. I can feel it just at the end there, but it's actually really difficult. And she's really trying, because she's in front of all of you, and she's really trying. So I get you to again, just try again for me. Okay, so that's a little better. It's getting there, but it's still all happening up here and very little happening down here. So it doesn't matter how often I say that to her, she's really going to struggle to do that unless I help her. So one of the things that Professor Kolar does, a really simple thing, I've never seen it before, and I just use it all the time now, is that you just bring your hands just over the diaphragm, and you squeeze, and you push down inferiorly. And what happens is you see immediately, you look at her abdomen, you see already there's a change in pressure in the abdomen, there's a little bit of a doming there. So if I now push here, that stops her being able to move the thorax so much. If I now ask her to breathe in, and you see her abdomen's moving now beautifully, and breathe out. So now she's beginning to feel what that's like. So if I sit there for a couple of minutes, just with her breathing out, I won't do it for the whole 2 minutes, but if you imagine if you were just doing that, and you see already her abdominal breathing has changed completely, and then relax and breathe. Now if I say now, imagine that feeling, I want you to try again, I just want you to breathe in down to my hand. And I'm actually getting movement there now, which I wasn't before, and breathe out. So then what I can say to my patient is, at night, I want you to lie in bed like this, just before you're going off to sleep and having nice dreams. I want you to practice breathing, and I want you to take 10 really good, slow, deep breaths, and I want it all to happen here and not up here. That's it, and breathe out. Good. And you see already, you can see the change that's happened, and that's just in 2 minutes. We've done nothing really other than show her what it feels like in order to be able to recruit the diaphragm properly. And breathing in. And I wish I could claim that for osteopathy, but it's not, but I'm taking it and we're going to run with it. But it's a really, so we'll do some techniques on that, how we can modify that technique more to work on the diaphragm. But I want you each just to try that, just for a couple of minutes each, just work on that breathing and see what you do. Perhaps when somebody's had a cesarean or anything like that, where you really want movement, because there's always a huge amount of fear around scars. Women are terrified of anyone going near the scar, they don't want to look at it. It's really, really common for women to say, you know, you ask them, how's your scar? I don't know, I don't really look at it. You'll get a few, but has anyone told you to do anything with your scar? Oh, no, I just, you know, they just said it will just heal and I'll just leave it. And they don't look at it and they don't do anything with it. And this, as a simple thing, even for the most fearful of patients, can at least begin to get movement back to this area, because they almost divorce themselves from everything around the scar. And it's very, very common. So that's number one. This pressure distribution is really driven by the diaphragm, but also by the hips. So when you think about how pressure changes, and this is from one of Baral's books here, just giving the different pressures at different points in the pelvis, you know, you can imagine that if this pressure becomes too much in the lower pelvis, that's going to lead to potential prolapse over time, and stress on the bladder as well. But there is this ring of bone, the pelvis, which if the pelvis is the right orientation, then a lot of that force, instead of going onto the pelvic organs, is going onto the hip and onto the pubis. So it's being shared inferiorly. Often we think of the pelvis as being more rounded than it is, but it isn't. You know, when you look at the proper orientation for the pelvis, the ASIS and the pubis should be in line. And that means that a lot of that vertical pressure which is coming from above is going to go to the pubis. But if you have a dysfunctional lumbar spine, you have a loss of lumbar lordosis, and you think about all those old pictures that Wernham would show about the posterior type, anterior type, and the different kinds of effects that can have on the lower pelvic mechanics, you're going to get this increase in pressure potentially. If the pelvis is rotated posteriorly, instead of that pressure going nicely onto the pubis, it's end up going to go onto the organs themselves. So when you cough and sneeze, more pressure goes directly onto those instead of onto the bony structures which are there to protect it. So we still have to pay attention to all the osseous stuff as well. We do need to look at how all that works. And so just, we can understand just how the impact of the abdominal diaphragm has on the pelvic diaphragm and the way that it will follow, the movement should follow the two. So, and so this, if you remember the old PA line, which Wernham would talk about, which is this line that runs from the posterior foramen magnum, and it goes down to L3, it splits at L3 and goes out to the two hips. So, you just have this drawing of a spine and this dotted line running down, and you think, well, it's all a bit arbitrary. How have they decided that? And so Renzo's put a bit more flesh on the bones by looking at some of the structures that are linked to that line. And Wernham did call this the pressure line. And let's see if we can get rid of that. Oh, that's rear TV. Anyway, so this idea... Oh, that's not good. He referred to this PA line as the pressure line. So if there's disruption to this PA line, it's going to alter pressure distributions within the body. And so if we then begin to look at that, this model here, we can see, then the suboccipit, the sternocleidomastoid, the mediastinal tissues, the diaphragm, psoas, piriformis, all have potential impacts on pressure distribution in the body. So even if you didn't do any visceral work, if you just thought, I want to alter this patient's pressure balance, I need to hit all of these areas. These are the structures you would want to look at. So if you're thinking, well, how do I treat the mediastinum? Treat the sternum, treat the ribs. Every time you do a GOT, articulation of the ribs, you are moving pleura. You cannot help but move pleura because it's adhered so firmly to those ribs. So as you get more movement in the sternum, you are going to influence these pericardial ligaments, you're going to influence the diaphragm. So really simple, year one stuff. But if it's done with the skill that you have now and the understanding that you have now, then it has, we talk a lot about intention. And if you've got a clear plan, okay, this patient's got prolapse, what am I going to do to help with that model? I'm going to make sure psoas functions well, I'm going to start with piriformis, I'm going to make sure the diaphragm functions well, I'm going to make sure the upper cervicals function well. You've got a treatment plan. You can assess and begin to address those simple things, but with a view to altering pressure distribution in the body. So that's where these things, these old models that Wernham was talking about are clinically useful. They're clinically useful. So one of the other models that we have in terms of pressure distribution is movement of the iliacs and the sacrum against the iliacs. So the first one is really quite straightforward. This idea we have of the sacrum nutates and counter-nutates, and that's sort of this motion between AP. This idea that the pelvis will move. You've got this tiny movement. It's not big, but it is important. And so you get this scissoring effect that's taking place through the pelvis. And as that takes place, while we're standing, as I stand and I slightly sway from forward to back, that constant movement that's always happening. We never stand dead still. Even guards standing outside Buckingham Palace are still swaying slightly from forward to back. And that mechanism is creating a little bit of pelvic breathing. Walking, of course, is going to drive this mechanism even more. That's why walking is one of the most fantastic things we need to do, because it gets circulation changes. But one of the things that are less well known is this idea of flare, in flare and out flare of the ilia. And so just to be sure we're familiar with what we're looking at here, so we're taking a cross section through the pelvis here. So we have a sort of approximate top of the iliacs here, we have down at the ischiotuberosities here. So can we fill in some of the gaps on what are muscles here? What are these muscles here on each side, do you think? Psoas, iliacus, good, okay, excellent. So then what do we have here? This one here. Say it loudly. Someone said the right answer. Say it with some conviction. Levator ani. Very good. Yes. Okay. And then here, obturator. Yes. And these are the perineal muscles, the transverse perineal muscles. Okay. So there's this idea also that the ilia make this internal and external rotationary movement around the hips. Around the hips. And we make use of this in childbirth. You know, we talk about the idea, ideally, for women who've got the mobility, we want to be able to counter-nutate and then nutate the sacrum for expulsion. So counter-nutate to allow the head to come down into the pelvis, and nutate to be able to expel. So there's that movement at the sacroiliac joint that needs to happen. But also, we want the ischiotuberosities to spread to allow the head to accommodate with that movement. And also for bowel movement, for emptying the bladder, all of those mechanics, we need that to happen. But we all sit on toilets, and so as a result, we sit on our ischia and we bring them together, so immediately we're fighting that, and we see, you know, what are amongst the most common medications that are dispensed or that are bought in pharmacies are, you know, anything to help with constipation. You talk to anyone who has constipation, you know, it's not a laughing matter because it's really unpleasant. And hemorrhoid cream, you know, it's massively prescribed. Why is that happening? Because we're sitting on the loops that are too high, we're not in a squat position. And I love this, if you're on Facebook, about 2 years ago there was this thing, it was about advertising, it had a unicorn that pooed rainbow coloured poo or something, and it was advertising the fact that when you sit on the loo, if you have a step in front of you, so that your feet are on a step, so it brings your knees and flexes your knees and hips, that opens the pelvis and you get much less strain. You're not the bowel will open more naturally, and so that's this physiology, this idea that the pelvis must move, but part of that movement occurs around the hips, and we get obsessed with the pubis and the SIs, and we forget the hips. So the next question is, well, how do we say? Yes, sorry.
Sorry, more basic question. Inflares related to the issue or the?
Oh yeah, that's a good question. I get inflare is that movement, so yeah, inflare and outflare is the other. I think I could be wrong, but I'm pretty sure that's correct. Inflare, outflare, yeah. So so it's this idea of this pelvic breathing. It's important how these joints function. So it relies on the health of the sacroiliac joints, the lumbar spine, the thoracolumbar fascia, and the hips. So, and obviously all of the muscles that work with that, and this pressure distribution that takes place. So, if you have tension, in psoas and iliacus, and that affects then the peritoneum tension, and it creates an imbalance in this mechanism, this pressure, instead of coming down centrally, is going to get pushed more laterally to one side or the other, and that potentially has an effect on, again, this pressure distribution. So we just want to think about this, how this works well. So we're going to look as part of the assessment, looking at how we assess the hip, as well as thinking about, you know, the sacroiliac joints and so on. And if we look at, again, what's going to be affected by pressure changes is the blood supply, particularly the passive system, which is a venous system, it's a low pressure system. So, and I just really put this picture just to show the vasculature, the level of that, and even this is still not close to reality of how complex this vascular bed is, and how important it is. But it's interesting, the ovary has a dual supply, and this also down to I'm sure the embryology. So you've got an ovarian supply will come via the supply to the uterus, so it will come along the fallopian tubes, but you also have this ovarian artery which comes out at about L2, L3 on each side, and comes down over in artery and vein, which comes down. It's a whole separate structure. So the ovary gets this dual supply, which gives, again, in essence, how important this structure is in our evolution. If we're looking to try and get the next generation, we want to make sure the ovary has the best chance of having a good blood supply to it. Was there anything new in this picture? Not really. Oh, yeah, no, not really. We don't need to worry about that. Okay, so nerve supply. When we think about fascia, it's all nicely dermatomal, which is good. So pretty well everything down to the peritoneum, the outer layer of the peritoneum just follows the dermatomes. So you already know the dermatomes, so if you can know the level there, then it will just follow that. And it's only the deep layer of fascia, the deep layer of peritoneum and the organs themselves that have what's more of an autonomic sensory supply. And this is one of the reasons why abdominal pain is so unclear physiologically. Has anyone here in this room had appendicitis? Yeah, one. Okay, so we have one case of appendicitis. So I'm really sorry. So I'm going to ask you, how old were you when you had it? Was it something that you could? So you remember probably? It was last week. I'm joking, but take it as a compliment. I'm just envious. So you imagine how did it start? Where did the pain start? Do you remember?
I was really here.
Straight away.
Yeah.
Really? That's unusual. No, but it is unusual because classically it will start centrally. And then it migrates over to the right iliac fossa and it becomes very localized. So that's interesting. We'll explain why that might be in a minute. So why do you think does it start this sort of... And usually, did you feel sick? Did you have sweats? Or did you just get pain? Do you remember?
It was mostly pain. Yeah.
Mostly pain?
It was different pain than...
It's not one you'd had before.
It was really different.
Yeah, so you're very aware that something was clearly not right. Yeah. And it's interesting because it's autonomic, the nerve supply, you get usually a very vague sensation of what's going on. Often there'll be a lot of vomiting as associated with it. So you think about the last time you were sick pretty well. I'm sure everyone in the room at some point has been sick in their life and you just remember that awful clamminess that you get, which is the autonomic response. And it's vague, you don't really know where it's all coming from. When you have a gut ache, when you've got an upset tummy, you can't really tell where it's coming from. And it's because we don't have a well-defined homunculus for our viscera. And so I can close my eyes and someone can come up and touch my hand or my toe and I can tell you exactly where it is because I have a well-defined somatic nerve supply or parietal system. The parietal system is very well defined, and so we have a good homunculus for that. We don't have that for the viscera. So it's why when people have a heart problem, they'll feel it in their arm, they'll feel it in their neck, they'll feel it and they get the sweats and all the other things associated because they're getting this an autonomic sensory system. So it's very vague. So often what happens is that with appendicitis is you've got this general grumbling, it's all a bit unhappy, you feel nauseous, you feel sweaty, and then the pain migrates. And what's happening is that as the inflammation gets greater and the deeper layer becomes inflamed, it then begins to inflame the outer layer of the peritoneum, which obviously happened. You were not picking up on a lot of the early symptoms, but once it became very localized and you were getting pain that was affecting your parietal system or the somatic nervous system rather than the autonomic nervous system, you're then getting very localized pain because that's that's where the nerve supply comes from. So once you get onto that outer layer of peritoneum, that is dermatomal, so you get very clearly localized pain. So that's just really just an explanation about how pain is very vague and why you can't always listen to your patients describing where their pain is. And in fact, they're being very specific about it. The chances are it's not coming from an organ, but it's coming from a more superficial structure because you can't be that specific about your organs internally. We just don't have the tools for it. So in terms of nerve supply for these different structures as well, they're just listed here. So I won't go through them all, but you can see when we test these structures, if you have a restriction at L3, we just need to give consideration to the fact that might be an L3 facet irritation of some sort, which is standard somatic dysfunction, but it might also be down to the fact that there's immobility in the in the ridges of the mesentery, and that's causing the restriction at L3. So people often think, well, why do I need to treat viscerally, when I've got a patient with low back pain? Well, the chance of the low back pain could be coming from that, and there are ways of beginning to differentiate in your case as to whether or not it's really a somatic problem or it's a visceral problem. Richard tells a lovely story of a patient who came in with awful apparent adhesive capsulitis in her shoulder, and her left shoulder, I think, and he said, it was very restricted, had all the classic signs of it, but when he did an abdominal screen, he really found that there was a huge amount of tension up around the splenic flexion, and it was much, much tighter than anything you could feel directly when you were testing the shoulder in terms of the tissue tension. So he took a gamble and started working around the abdomen where the tension was, and he said it didn't happen instantly, but he said within 3 or 4 sessions she'd gone from 0 movement in her shoulder, apparent clear adhesive capsulitis, to one where she had absolutely full range of movement restored, and he didn't do any treatment on the shoulder at all. So, that's where you've got to make these clinics. You can imagine, we have these cases where you spend 6 months trying to work on these shoulders and then gradually making a bit of progress each week. You do your finger walking, do your triangle exercise, do all that. You're just like, damn it, just get better, this is another way. And they are really frustrating. And so it's always worth considering, that there may be other causes. We don't just treat people viscerally when they have a gynae problem, or they have, apparent gut problems. It plays a big role in musculoskeletal, apparent musculoskeletal classic presentations. Again, I just put this in just to show some of the blood vessels. This is an important one. Okay, yes. So this is just a part of the pudendal nerve. The pudendal nerve is capable of having something called a pudendal nerve neuritis, and can be a cause of chronic pain in the pelvic floor. And so when I was talking about the sacrotuberous and sacrospinous ligaments earlier, why we need to be able to palpate those, is that you can see that the pudendal nerve passes around the sacrospinous ligament, and when it passes forward into the pelvis, it passes through that space between sacrospinous and sacrotuberous ligament. So you then have this Alcock's canal, which you can palpate internally, but actually you can have a huge influence on this by working in the posteriorly in the fossa. I can't think of, my brain's gone Saturday. We'll show you the technique for this later. But it's just very important that we can get to this nerve, and it supplies all of the pelvic floor. It's also responsible for clitoral sensation. So it's really, or branches of it are important for that. So it's very important. So I show this picture not because this is anything we're ever going to do, but just, and it's actually not used that commonly here in the UK. It's a pudendal nerve block. They use it a lot in the US. But it's just, how do they do it? Again, it's really useful because one thing that midwives do use when they're palpating internally is the ischial spines. They do palpate for the ischial spines, and the sacrospinous ligament attaches to that. So they look for the ischial spines and inject there, and then they know that they're then going to numb the pelvic floor. So that's where you can do a pudendal nerve block. So it is one of the easiest. If you do decide to do internal work, then you look for those spines, and you can treat around there, and you can treat any tender points, trigger points that you discover, and that can have quite a significant effect on pelvic floor pain, because you can change the structures around the pudendal nerve. And certainly in private medicine, you're seeing women who are having surgery internally to try and do a release on the pudendal nerve, and it doesn't work. It really doesn't. So anything we can do to save women from having to go through that. But this is just instructive, so you can just see where it is. Okay. Right. Okay. Bladder mechanics here. Again, we've got these 3 ligaments here that I was talking about earlier, median and 2 medial umbilical ligaments. And we can see then there are these lateral supporting structures for the bladder. And this is a male model because it's got a puboprostatic level, but actually the anatomy is very much the same for men and women. So you have these ligaments which come anteriorly from the urethra onto the pubis. So you begin to think, if you've got a case of incontinence or stress incontinence, you want to be able to access these ligaments, but you also then perhaps want to treat the pubis to make sure the pubis is functioning well. So we look again just at more of a schematic diagram showing the different attachments of the bladder. So pubovesical, pubourethral ligaments are all very important. We can have an influence on these and treat externally as well. And if we look at the ureters, often we think of the ureters just as tube that connects the kidneys to the bladder, but in reality, if there's a tube there, that can have a mechanical effect. So you can also indirectly treat the bladder by, say, tractioning on the kidney. You can lift the kidney, that's going to create a stretch on the ureters on each side, that has a mechanical effect potentially on the bladder as well. If you're looking at a way of trying to influence it, remember all these attachments that are there. We can use the blood vessels, as a means of mechanically influencing organs, because these ligaments and blood vessels and nerves all travel together. They can be and any one of those structures you can generate traction or tug on to create changes if you can't get to the organ directly. So there's just ways of thinking about that. Okay. This one I just want you just to see again anteriorly how thick the fascia is here. This is why you can't palpate much. If you just palpate from the pubis inferiorly going down toward the ischial tuberosities, you find that you really can't get into that space and treat in any meaningful way externally because of this thickened fascia here. It's very thick, and it's there because the bladder sits on top of that, so it's important, and it carries a lot of the weight of the bladder and uterus. This is again just showing more pictures of the ligaments. These are all in your handout, so I won't spend lots of time on that. These are things you can just look up and see. This is an opportunity just to talk about a bit about incontinence very quickly. My quick 1 minute or 2 minute explanation, because there's quite complex interaction between the sympathetic and parasympathetic nervous system to allow the bladder to void. Really all you need to know is that before you learn bladder control, your bladder was quite happy. The kidneys would filter everything, it would go down, the bladder would fill, it would reach a preset point, stretch receptors would go off and say, oh, yep, bladder's got full, we now need to contract. So the wall of the bladder contracts. The internal sphincter, which is completely under autonomic control, also relaxes at the same time. And so you voided your bladder, and you were just quite happy playing, you had a nappy on or whatever, and everything just carried on, and you didn't think about it. And then it became a bit more of an obsession for your parents. Once you get to 2 or 3, they wanted you to start to control this, and you realised you could, and you had great power over your parents, and you control their life and make it really difficult if you started to play around with this. And so you could get yeah, everyone giggles. We've all been there. So if you've had children, and then of course, and all of that control comes from the external sphincter. That's the only thing that prevents the bladder just spontaneously emptying. So your bladder really is working against you. Once it's got full, it will start to contract. So there's a reason when you start, oh yeah, I need to go. Oh no, I really need to go. And the more you think about it, the more you need to go, because actually there's this feedback loop where it's starting to contract. And the internal urethral sphincter is relaxing at the same time. So that's the parasympathetic nervous system doing that. Sympathetic nervous system basically keeps it all, stops you from peeing, and then the parasympathetic kicks in and will cause you to want to empty your bladder. So it's interaction between the two. And so it's all down to that external urethral sphincter. That's what stops embarrassment occurring. That's all there is. And that gets potentially quite damaged with childbirth. So we'll look at that sphincter later, but that's really essentially the potted history of what we need to understand with that. So these are just looking at the different cross sections where what really forms this external sphincter is this ring of muscle that sits within this thick membranous area which I was talking about before. You have this striatic muscle which is under voluntary control here. Okay. So that's quite easy to think about. We can picture that. We've got the 2 sphincters and we think, yeah, okay, I've got that all clear. But there's more. If we look at this as a cross-section of the urethra, okay, and we see that this inner mucosa, the health of this inner mucosa and the spongy coat is really important. If that area becomes less filled with fluid, suddenly, no matter how good your sphincter muscles are, it's going to be much harder to occlude that space. Can you picture that? Yeah? So we really need to have good blood supply to these cells so that we have good health in the in this mucosa, in this inner mucosa and the muscular coat. All of that, it's very important that we have that. So that's why we think about circulatory dynamics. We want to make sure that there's a good blood supply and drainage to the urethra so that it's in good health. Because when you palpate internally, and because the urethra on a woman is very easy to palpate internally, but it's very easy structure to identify, and when it's not healthy, you feel there's almost like granular tissue around it, and you just feel the urethra itself doesn't feel healthy. So you can teach women to gently massage this area so that they get a better blood supply to it. Even if you don't want to treat it, you can teach them to because it's really very external. You know, it's very easy to reach. You know, you only really need one section of your finger to be able to reach internally, just to be able to massage and work on the urethra. So even if you don't want to do any treatment there, which is absolutely fine, but you can give instructions on how they can massage this area, because you can alter this localized circulation and alter the cross-sectional, urethral cross-sectional area. And then this is more, this is really following the rule of Christian Fossum, is that you must have at least one unintelligible slide in your presentation that nobody really understands, but it looks pretty. So that's the lower one there. We have lots of sort of ligamentous structures, which I wouldn't care to name, but it does give you an idea of what's going on. Yes?
Sorry, would you be able to give us the instructions you can give to a patient? Are you going to do that later?
Yeah, I will do that, yes. Yeah. But I would say, yes, I mean, yeah, because I talk about this a lot in children's, in the women's health clinic when we talk about pre-birth as well, perineal massage. I don't know how many of you ever talk about perineal massage to your patients and how you give instructions on how to do that. Would it be helpful if I just talk about that now, because I'll probably forget later. So we can just do that now? Yeah, because it's practical, how you would talk to your patients. So, yeah, I basically say that the evidence now is quite clear. It's even on the NHS website now. So it's reached that level of evidence now that it's considered to reduce risk of perineal trauma and reduce risk of third-degree tearing if women do this from about 34 weeks onwards. What I say to them, in effect, is you need to use your thumb. You place a foot on a, so it could be in the shower, and you get a little stool or something like that in the bathroom, and you're just going to place your thumb just on the back wall of the vagina. So I say you just place your thumb internally inside the vagina, and you're going to apply a pressure directly backwards towards your anus, and then you're going to go slightly laterally on each side. You'll feel the instruction is that on the NHS, it talks about, the website talks about that you push enough that you create a small level of burning within the tissues. You shouldn't spend more than 5 minutes doing this movement, but that it will create a localized burning and get a little bit of relaxation. So I say you just apply pressure, not big discomfort, but there's a small level of discomfort. But what I think is actually most useful is I say that you try different breathing techniques while you're doing it, and you will find that with some particular breathing techniques, you'll find your pelvic floor relaxes very quickly. And I want you to learn this reflexly so that when you're in childbirth, you can learn to relax this area in the same way. It's a reflex. So women can do this, and particularly when they learn to get pressure on the perineal body, I don't use words like perineal body, but when they're actually on the perineal body, that can create a huge relaxation in the posterior vagina if they breathe correctly. And you can use this for patients as well who are scared about having sex again after pregnancy, that they can learn to do this self-massage to start with, and again learn to relax, and then say you can teach your partner to do this first so that it makes penetration more comfortable, and you know, so there's a lot of discussions which you can have around this if you're prepared to have the conversation. So that's number one. That's what I say to patients who are, you know, in terms of perineal massage. And what I would say to a woman if she is coming with stress incontinence, I'll say, well, one of the issues with your urethra, it's a little tube that connects your bladder to the outside. It's very short. It's really only this long. And you want to just, you can find it on yourself by, if you insert your index finger into your vagina and just push against the bone in a forward direction. So you're just pushing forwards, and I do lots of actions, kind of just demonstrating. So you're pushing forwards. You'll be able to feel like this little tube there, and all you want to do is apply pressure on that, and then gently try and slide the tube upwards and then gently pull down. So you're just going to push up and down in a direction, and then you're going to try gently going laterally. Not to the point where it hurts, not to the point where it causes you any nerve tingling, but enough that you just adjust. You can do this for 1 or 2 minutes, and you're going to do this every day, just for 1 or 2 minutes, and you'll get a localized change in the tissues. It will have a reflex effect on your circulation to the urethra, and it will start to become healthier. The tissues will become healthier. Okay, so that's the kind of explanation I would give for a patient.
Sorry, is that towards the pubis?
Toward the pubis, yeah. So it's on that anterior surface of the pubis. So just literally, you say you find your pubic bone at the front, you just want to go around the back of that.
Thank you.
Sorry, is there a way of a man being able to do that as well?
What, to his partner? Yeah, absolutely.
No.
To himself, sorry, yeah. Well, yeah, not easily, no. They would have to do, yeah. I mean, there are some guys apparently who do regular sort of prostate massage, and it can. It's an interesting experience. I went on the Molinari course, and as part of that, you're a man on the course, and you do. There's a very interesting dynamic when you're coming to do techniques. You usually like to be able to kind of share your body around, so it's part of the deal. And obviously, as a man, you don't have a vagina. You can't participate in those techniques if that's what's being taught. But what we do have is a prostate, and so. There were, I don't know, out of a group of 30 of us, I think there were 4 men on the course, and if I say that on the days we did prostate exam, there were kind of almost like a line next to you. You're kind of, oh yeah, okay, yeah, that's fine, just kind of do that again. But what was really interesting about that experience, having had your prostate massaged in that way, that actually, this is on video, isn't it? God, I'll never be a politician, can you imagine? But the effect was really remarkable. Like I said, it was quite different, because I'm a man who's approaching 50. I'm not far away. I just had my 49th birthday, so there is, as all men of my age and older are beginning to experience, you get prostatic enlargement, and it really feels very different, and I think there is probably real therapeutic value in having prostate massage, and what we do know is that it has a massive impact on PSA levels, that you shouldn't have a PSA test having had a prostate exam for at least 2 weeks after, and so because it will it'll give you a false positive, so it really will change things. So so I think there is probably real value in that. So joking aside, yeah, there is working on the prostate, but it's the only way really. There is a technique we'll do later which you can influence the prostate externally, but by far and away the most effective is to use a rectal technique, just working on it.
Sorry, could you repeat that last?
So you can work on it externally, which I'll show you, but mainly the most effective way to get to the prostate is internally via the rectum. It really could be beneficial if we could overcome the social taboo of it. There's be some quite interesting work that could be done around that, but men being men probably would never allow that to happen. Wouldn't go along with it. So these are all just pictures just to show the different support structures around that. Just revising what we've done. Uterine support structure is very similar to that of the bladder, and also on this picture you can see that the round ligament is shown very nicely here as it comes out and round and over to the labia here, to the anterior portion of the pubis there. So that's what that is for. I love this picture because I think this beautifully shows what the ligaments of the uterus are for. So we have the round ligament here, really like a guide rope, I love this. It gives tension to the uterus, and these uterosacral ligaments here, and the broad ligament here laterally. So you can see they affect the position of the cervix. They're really, really important. I just think this is a beautiful picture. Really, really good. Okay, this picture is just to help us differentiate between what we mean by anteversion, retroversion, and anteflexion and retroflexion of the uterus. You will occasionally hear women say, oh, I've got a retroverted uterus. And you'll go, oh yes, okay, good. And you'll either know what that is, or you'll go, I think I vaguely know what that means, but I'm not sure. So there's a simple effect. If you are palpating vaginally, and so this is the anterior, this is posterior, as your finger is inserted and you come up to the cervix, The cervix you should feel slightly anterior, just above the pubis effectively. If you imagine, it's not just above the pubis, but it's in the same plane as the pubis. So it should be anterior, and that is anteversion. So that's this angle here between the axis of the vagina and then the axis of the cervix. So if you have this angle, this forward angle here, that is called anteversion. So think of the V being for vaginal, this angle between the vagina and the cervix. So when you have a retroverted uterus, it's really retroversion of the cervix, so that it's much more in line with the axis of the of the vagina, and so it's much more likely to prolapse. That's the big risk, because it's now, instead of sitting at this angle, it's now much more likely to come down like this. So version, anteversion, retroversion refers to the angle of the cervix with the vagina. Whereas flexion refers to this angle of bend within the uterus itself. So between the lower and the upper portion of the cervix, you have a natural anteflexion, and you can have a retroflexion of the body of the uterus against a normally anteverted. So you could have good anteversion, but you could get retroflexion of the body. Yeah, so anteversion and retroflexion. So flexion is just the angle between effectively the cervix and the body of the uterus, and then version is the angle of the cervix to the vagina. That make sense? Yeah. Okay. And then I just like this picture. Look at all the vasculature of the roots of the mesentery. Remember, this runs from ASIS through the umbilicus on a diagonal line. The reason we want that to move well is because look at the vasculature here that sits there. If we're serious about getting changes to circulation, we need this to move. Okay? We can do all this stuff about eating wine, or I don't think so. I don't think we've got time. Okay. Zip through that. It's all good stuff, but for another time. Yes.
Excuse me, just in relation to the movement, in your experience, have you come across many severe reaction to treatment, immunological reaction, literally, from having had abdominal type of visceral work, release of scar tissue, things like this, rheumatoid arthritis, or severe?
I've personally not had that as a reaction, no. Sometimes people can feel a bit rough for 24, 48 hours afterwards.
Symptoms.
That flu-y type symptoms, but that would be the worst of it usually.
Yeah.
I've not come across any other sort of full-blown.
Yeah.
In fact, if I've got cases of people with RA, then I will, because often you can't do anything with their joints, they're so inflamed, I would look to the abdomen to treat as a way in. Because often that's the only way that you can get some response. You might be I'd be looking to try and calm the whole thing down rather than, stirring up, as we see with that sort of inflammatory feel that you get. It's a good question. I haven't experienced it. I guess it's possible, but I haven't.
I was interested to know, because of course you work in the field maybe using visceral a bit more than your average osteopath, so
Possibly.
your risk would have
maybe,
increased, but
well,
you still
worrying
haven't.
now.
No.
If there's not something that's come
That's
across.
very interesting. Thank you.
Okay. So just a final thing I just want to talk about in terms of anatomy is really just looking at the ovarian anatomy. Because really just picturing these ovarian ligaments. Has anyone got like a big scarf or a blanket type thing that I could use as a drape? Okay. So you're going to have to use your imagination here, but I'm going to be... So we're going to say this is folds of peritoneum here. And I'm going to be a uterus for a minute. Okay. So these are my fallopian tubes out here. Out here, you see, they're draped down. So you want to picture that. Okay. So if you picture my fallopian tubes are out here, and this is peritoneum draped either side. So that becomes the broad ligament, effectively. And you've got this double layer here, and then we have the ovaries sit at the end here. Okay. But you can see with this broad ligament that the ovary sits just behind here, and it has an attachment, or an apparent attachment, to the broad ligament here. And then it's got a ligament that runs back to the body of the uterus, and another ligament that runs laterally to the pelvis, lateral part of the pelvis. So in theory, the uterus shouldn't move around much. But when we talk about ligaments, what we're really talking about is peritoneal folds. That's more accurate to think about it. So if you imagine in fact, that when we talk about the uterus being having a ligamentous attachment, really it's within this peritoneum itself, so it's come back, and that's what's creating the ligamentous attachment. And then it's folds of peritoneum that go laterally and medially to the uterine body. So that's what allows the movement to occur in the ovaries. Once you've had children, that's going to, they get moved because obviously the uterus grows enormously. So there will be change in position of the ovary. So I think this is quite useful to picture all of these support structures, but ultimately it all comes down to this peritoneum, and it gets very confusing if you start calling it all by the correct anatomical terms. Frank would be, appalled at my absolute destruction of, anatomical terms and, just creating these very general terms. I wouldn't pass any anatomy exam by doing that, but in terms of trying to think of the structures as a whole, that's what you've got to think of them as being part of the same thing, because then you can realise when you influence the bladder, you're going to influence the fallopian tubes, you're going to influence the uterine body, you're going to influence the rectum. All of those structures are brought together because, this peritoneum is just folding over me, so I'm anti-flexed here, but it's going to come up forward and attach up to the pubis anteriorly here and going over the bladder, and behind me it's going to drop down into that pouch there onto the rectum and then come back up and then up toward the anterior surface of the sacrum. So when you think about that continuity, when you treat the sacrum and you spring the sacrum, you are going to treat the uterus, the bladder, the rectum. You can't help but have that. You may not have that in mind when you're doing that, but that's what you're doing. You're already doing it. You're already treating viscerally, whether you think you are or not. Anytime you try to influence the hip or the pelvis, you are already treating viscerally. Every time you treat the thorax, you are treating the viscera. It just means that we can be more specific with our hands and our intention if we can picture these relationships and try to get a grasp of those. But all of these are very available images. They're all ones I found on Google, so if I can find them, I know you can. So you can see these ovarian, uterovarian ligaments and so on. One of the best videos, I don't know if any of the others have come across these, really helpful, is the Snell videos. You heard of Snell, the anatomist guy? Okay, so Stanford University did a joint study. These are all free on YouTube. You just put up Stanford Anatomy, and you look up a Snell Stanford Anatomy, and they've got all of his videos, about 9 or 10 videos, they're about an hour each, and he does all of the drawing on a blackboard. You've got all different coloured chalks. It's the most extraordinary way that he can build up the anatomy, and he does it in such a way that you'll really be clear about. So that he's got there's two lectures on the pelvis, and it's brilliant, absolutely brilliant. So I just highly recommend it as a resource to go to. Okay, lovely. One of the ligaments of the uterus here, and we can see these ligaments I've been talking about. But here you can see we're looking laterally at the uterus here. You see the tube, and then we see the ligament of the ovary and the round ligament of the uterus. They all come from one spot there. So you imagine the draping of the broad ligament here over the fallopian tubes, over the fallopian tube here, but it's also over the round ligament and over the ligament of the ovary here. So it's all included. So when you're working on the pubis and you're trying to influence the round ligament, if you know that your patient possibly has mobility or motility issues in their uterine tubes, you're thinking about fertility, then you want to make sure the round ligament is under, you can influence that. So when you're working on the pubis and you're trying to influence the round ligament, if you know that your patient possibly has mobility or motility issues in their uterine tubes, you're thinking about fertility, then you want to make sure the round ligament is under, you can influence that, you can work on that. If you can mobilize the ovary, you create stretch here, again you may have an indirect effect on the circulation around the fallopian tube. So it's just thinking about these relationships, rather than coming up with particular techniques, think about the relationships, think about what you're trying to achieve, and just make the technique up. Most of the time, I shouldn't say this, but I've got students here who might be with me next year, but most of the time when students come in, can you do something on this, or what do you know? I just make it up. It's not a technique I've been shown. I just kind of think, okay, patient's lying down rather than sitting, so I'll think of something in that position, and rather than make them move, I try and think about how to make it happen. You feel the tension, you get on the structure you want to influence, and then you just do what you need to do. And you don't really, I don't have a big log of techniques up. I might have a few, but most of the time I'm just trying to think about what I want to achieve with that, you know, with the technique, and just make it up on the spot. And sometimes they're quite good, and then other times I think, well, I can improve on that. You know. But you know, it's not about learning technique. It's about trying to just picture the anatomy and why you might be trying to influence things, and seeing those things is quite helpful. How am I going to do these now? These, I think, again, are self-explanatory. They're all techniques that you will know. I put them in just as when I was talking about this minimalist, maximalist, and symptomatic approach. These are all techniques you could use just as a general tonic for a patient. If you don't know the GOT, if you didn't train at the ESO and you trained elsewhere, and you think, well, what can I do, you know, as a general tonic to boost this person's general physiology? The set of techniques here which I put in, and there's explanations for all of them, how to do them, rather than spending time on these now. If we have time, we'll do them at the end, but I think these are all ones that you can do. They're very simple, but they all work on the autonomic and circulatory model. They're all looking at trying to influence drainage and circulation. Okay, so that's these techniques that are put together. They're very, very useful. So all of these alone, if you don't do any visceral work, you can just do these, and these will still have an effect on patients with women's health issues, because they'll be addressing circulation dynamics. And much of what we want to achieve with the women's health work is improved drainage, because most of the problems are to do with congestion of some sort or another from the pelvis. This last technique here, I really like the hepatoduodenal ligament. I put a picture there just to show, not the clipping bit, but it just shows the anatomy here. You can see how much is held within that hepatoduodenal ligament. So you've got the biliary tree, you've got all this portal system as well. And I hope none of you are in the situation that I'm in, but it was quite a discovery for me a few years ago. Fewer than I'd like to admit to, really, but that everything, that all the blood that goes into the gut and all of the, you know, small intestine, large intestine, all of that, before it passes back into the general circulation, goes via the liver. Some of you may not have known that. I didn't know that. I managed to graduate and not know that for quite a long time. And it was like, oh, that's why we have to treat the liver all the time. You always hear visceral osteopaths always talking about this idea you have to treat the liver, and even, you know, the classical osteopaths talk about you must treat the liver always, and it's because everything has to go through there. And medically, we know that. We think about ascites. You know, what's that? It's just an accumulation of fluid due to cirrhosis of the liver. The cirrhosis of the liver is causing backflow of circulation. It can't get in there, so that fluid has got to go somewhere, so it comes out through the capillary beds in the abdomen and accumulates this fluid within. So that's a pathological state. But for osteopaths, when we think about a functional state, you know, the liver doesn't move well, then that's going to have a big effect on the venous supply or the venous drainage from the abdomen generally. And so people who don't feel well and they've got this general abdominal sluggishness or congestion, you want to treat the liver. And you know how to do it already. It's very easy. You just do the simple pumps. What I just did with you earlier, you can modify that to turn it into a liver pump. You know, really simple stuff. It's not about teaching you something you don't know already. It's just simply applying what you already know in a different way. So I'm sure none of you are in the same circumstances as me, but just in case you were, I thought I'd put that out there just so that you don't labour under the same problems that I have. Okay, so now we'll get to the Women's Health Clinic protocol. That makes it all sound very grand. This was Michael's guesstimate at how to set up a way of doing something and teach students something in 3 weeks. So the first 3 weeks we teach it to them, and the last 3 weeks they have their clinical rotation with me. I can supervise them doing the treatment rather than me doing it all the time. So this is what we do. And we're going to spend the rest of the day sort of looking at this and how we can begin to piece together where we think we need to treat. Because sometimes, you know, I do still love to do adjustments. So I still love articulation and MET as well as visceral and cranial work. So we can do all of them. We have a standing, sitting and supine routine, and I want us to go through all of these things so that we just get a sense of what we're looking for, and then from this it will generate a little manipulative prescription. So by week 3, usually of the rotation, my students know this routine, so they'll come in and I'll come in and I'll say, okay, so what have you found today? And they will say, you know, I have found restriction on the left kidney is toes, the root of the mesentery is held inferiorly, the uterus is held to the left, the sigmoid colon is restricted, the left obturator is compressed. And so they give you a list and you say, okay, then I say to them, which of those is worst? I make them make a decision as to what they think is the most, when I say treat that first, and then re-examine, and then keep treating until they've all gone. And so we have a little protocol for all of that. So initially, in the first few weeks, I'll say, okay, so what have we found together? And I say, right, you want to treat the uterus, you want to treat this, and you want to treat this in that order. And then they go away and they treat it, and then after a while, hopefully by week 6, I'm just sitting in the tutor room doing nothing while they come back and tell me, oh, I found this, and then, yeah, okay, get on with it, you know, and go away. So that's what you want to happen. So, generally, it's been, for those that have wanted to engage, it's worked quite well. And it's all, I've been very lucky previous years because they've made it a voluntary rotation, so students are there because they want to be, and they have to come in and do extra time to do it. And now, I've moved the clinic time, but students don't get a choice, they just come to me, so some of them definitely probably don't want to be there, especially just pre-dissertation time, quite a challenging time at the school at the moment while they're doing all that. So I feel a bit bad for them because they're not, you know, they're not there by choice, they're there by, you know, they've just been assigned to me, which I think is a bit of a shame, but I guess it's just, you know, the way it is at the moment, because they're a large year, they apparently hear that's a lot. So that's where we are. So this is the routine that we teach. So we're going to start, first of all, so if I can have a model and we'll do the standing screen first of all and what we're trying to achieve. Yeah, that's fine. So, so you can just stand. So first of all, I've got this idea that first, let's move over this way because we've got the camera over here. That's great. Okay, so the first thing we want to do, I'm going to stand you sideways, and we're just going to take a contact, just resting our hands on the shoulders. It's almost the most natural thing that we do when we first make contact with a patient anyway. It's very reassuring, but we might as well make use of it while we're there. So if we're thinking from a circulatory point of view, all drainage of the lymphatic system is going to come back via this space. It's going to come back between the clavicles and the first group. So we really want to get an idea of how this is. So you just place your hands on very lightly, and I'm just creating a little AP compression there, and I'm just trying to make a decision. What do the scalenes feel like? Is the rib, does it feel hard? Does it feel soft? Is it elevated? You know, what's the quality? Does this feel healthy? And if it feels tight and compressed, I already know that there's going to be congestive issues in the body, without question, because this is a terminal point for it, and so that's the number one space we need to go for. So number one, that's the first thing. We just listen at the shoulder. So this is not the same fascial listening that Richard does, where he kind of puts his hand on and go, oh yes, there's tension down in the right. I can't do that. I've really tried, but I just can't do it. But he and I taught a lot together a couple of years ago, and we discovered we find the same things using this test. So we agree, which was really nice, because I was like, I can't do that, so I just need to find another way. So this is what we're going to do. So you're making an initial assessment, you just see, and really what you're trying to assess for is what's the reactivity of the tissues when you compress? Do they push back against you, or do they accept what you're doing? And that's really the key. That's, if you go away from nothing else, with nothing else from today, I just want you to trust that your hands, when you're making a decision, these are your osteopathic decision-making processes. What do the tissues do when you challenge them? How do they react? And that will determine whether the tissues are in dysfunction or not. And the level of reaction will tell you the level of dysfunction within the tissue. So it allows you to compare a restriction in the spine to a cranial restriction to a visceral restriction and decide which of those is primary, or begin to. I can't promise you nirvana, but you know, it at least gives you a chance to, you know, make an educated guess. So we listen at the shoulders, and then we talk about this idea of spinal density palpation. And you know, I've been heavily criticised by other members of faculty for using the term density, because apparently it's all incorrect. And then I came across this lovely new textbook, absolutely brilliant. It's called A Textbook of Osteopathy. It was published in German first of all, and then it's been published now in English. It's about £110, so it's very expensive. But It's amazing. One of the best academic non-American textbooks that's been produced in recent years, and really extraordinary. And it goes through the whole.
By whom?
Oh, I knew you were going to ask. I'll think about it. I'll find it and I'll write it up once I can't think of the name right now. It'll come to me. So the and in there they talk about density as one of the 5 things that you can palpate in palpation. So I felt validated. It made me feel that I wasn't being talking nonsense after all. But it's just this idea of just palpating for density. So we start in the neck. We palpate for the articular pillars, run our fingers down the spine, and you think, well, what's here? We've got spinous processes, we've got erector spinae muscles. So as we run down, and you just want to see where do you get drawn to as you're applying a little bit of PA pressure. So from the posterior to the anterior, you're applying a little bit of pressure, and that is a test. So you're already testing the tissues. And it's very interesting, you can do this with first year students on day 1, because they're human beings, they can do this, and they haven't got any of the stuff in their mind about whether they can or can't feel anything, or any distractions of anatomy. They can't tell you what they feel, and actually sometimes they'll go, well, I can't feel anything. And they keep stopping at the same point. They keep going down this line. I can't feel a thing. I don't know what you're talking about. And you say, why are you stopping there? Well, I don't know, but I just, And you realise they're stopping over the area of dysfunction. They can already do it. And somehow we unlearn this as osteopaths. We get in the way of this natural palpation, which we all have. So this will lead you to these areas of, and I could give you more of the physics of what we're looking for, in the sense that if you go next to the spinous processes, there's a little gutter there, and you'll feel somatic dysfunction as a fullness right next to the spinous process, and that's because the little monoarticular muscles are contracted. But that's almost too technical. What you'll feel is it feels harder. If you're on skin, your fingers will stop more readily at that area, and it's this superficial fascia. That's what you're feeling. You're getting a sense of what's going on. So you want to go all the way through the cervicals, thoracic, lumbar, and you'll feel areas of density. Now, obviously, some structures are naturally more dense than others, so it's not just enough to put your hands and go, well, that feels hard. You've got to test it a little bit, which is where this anterior pressure is. It's only a light anterior pressure, but it's enough that you then slide down, and that will give you enough of a test of the structures to feel the dysfunctional regions. And you'll be able to pick out 2 or 3 dysfunctional regions that are tight, and you can make a decision which of those is worst. We'll just make a note of the level. I felt something at L5, I felt something at T4, and I felt something at C5 on the right. So you can sort of very quickly pick up those areas. So that's number 2, so spinal density pressure testing. And then we're going to test the cavity pressures at each cavity. So we start with the head. And this is, for those that do cranial a lot, this is going to be very different to how you work. You're going to have to compress the head much more than you perhaps feel comfortable doing, but you're not going to do any damage, I promise, but you will feel stuff much more quickly. So you can apply a compression over the frontal, over the occiput, and I'm literally just bringing the 2 together. And I'm first of all just asking the question, where do I feel hardness? Do those tissues push me away? And in Roz's case, I can feel tension over the frontal area there, much more than over the occiput. So then I can get more specific, and I can, if I want to, I can then come down over the suture and apply pressure, and then just do a little bit of a slide. So it's like a fascial test. I apply pressure, I can apply a little bit of a lateral test, I can test for torsions, I can test any of those spinal patterns. But if you don't do cranial, it's just enough to know, do I feel tension more in the head? When I compare it then to the thorax, I'm going to compress over the upper thorax, so sternum, and left and right, upper thorax, lower thorax. So if I turn you around so we can see the contact here, which I'm making. So I'm applying a pressure here, and I'm just really looking for spring back. Does something push back at me? If something pushes back or resists me pushing, that's more likely to be dysfunctional. Okay? Then we go to the epigastric region, umbilical region, try and relax the abdomen, there we go. And then we just come, and I'm going to take a contact just on the lower abdomen, so I come suprapubically, so I take an ulnar contact, and I apply a posterior pressure. My hand is supporting her pelvis as I'm doing this, and I don't spend a lot of time doing this. I've just enough time for me to go, do those tissues give, or is there tension? So that then allows me to scan each of the 3 cavities of the body. Okay, very quickly it will determine where do I feel all the primary tension is in the body quite quickly. I can get that sense from standing. Okay, so I think we should do that first of all, just spend the time. So first of all, just this contact here, then this density testing as you go down. And it's not, I mean, you can introduce a little bit of oscillation if you want to, that's fine, but it just needs to be quick. It's something that you can do in a minute and make a decision rather than taking 10 minutes and not being sure what you're feeling. So it is about gut feel. What do you feel? Okay, and making a decision. Okay?